Good afternoon. I'm Dr. Phillip Kravetz. I'm here to give a little introduction to minimally invasive spine surgery. This is something new for us here in Cullman, so I'm not sure how it's going to go. Hopefully this goes really well. I hope there are a few people out there watching. We're happy to answer questions at any time, but I'm going to go through a little bit about minimally invasive spine surgery, go through some definitions, show a few pictures, and see what we get. First, a little about me. Born and raised in Michigan, went to college in Arizona, went back to Michigan for medical school, did some research out in Boston, went to Chicago, back to Michigan, then to Houston, finally started practicing almost 20 years ago in Dallas, and I started doing minimally invasive procedures almost 20 years ago, right when I started, right when this whole field was just starting. And I just recently moved here to Cullman to continue my practice. A few things about spine problems that I'm sure most people could guess. This is common. At any point in a year, 15 to 20% of people have spine complaints. That's of the population. That's pretty high. 80% of people, 80%, 8 out of 10 will experience severe, pain sometime in their lifetime related to their spine. 8 out of 10, that's pretty significant. Now, when people do have their complaints, typically they'll either see their primary doctor, often chiropractors, and once in a while they'll go right to the specialist. Certainly there's absolutely nothing wrong with, and I even encourage people to start with their primary care doctors or their chiropractors. And I hate to say this, but having recurrence of these spine problems is common. It's frankly expected, and that is one of the reasons why it isn't a bad idea to go see somebody, get things checked out. It may just be a matter of education and management, but this, once it happens, it's probably going to happen again. I put this statistic up again, 80%, 8 out of 10 people in their lifetime will have a severe episode of back or spine issues. Now, the truth is most people, regardless of whether it's back pain, neck pain, nerve-related pain, will get better regardless of what you do, even if you do nothing, after 6 weeks. 6 weeks sounds like a long time when you have pain, but the good news is that most of the time things get better. And the other is, we always worry about what do our x-rays show, our MRIs, all these different pictures and tests. Most people walk around with things that we would call abnormal and don't even know it. So having something isn't necessarily mean that you're going to have problems. It's part of the aging process. I'm going to go through a few definitions. I'm sure you can find different ones. These were ones that I made up that I think explain common terms. This degenerative disc disease, well, it's actually not a disease. Now, 100 years ago, everything was a disease, so they named it disease, but when every person in the population wears out their discs and has degenerative discs, it's hard to call it a disease, but it really just means the normal aging or wear process. Spinal stenosis, stenosis means narrowing, so it's narrowing of the spinal canal. A herniated disc, well, that's when the disc material pushes out. Typically, we worry when it's pushing towards the nerves, but pushes out beyond its normal margins. Radiculopathy, sciatica, that just means symptoms of a pinched nerve or irritated nerve. A few more definitions. Scoliosis, a curvature of the spine. The truth is it's really a pretty complex three-dimensional deformity. Hate to use that word, but that's what it is. Spondylolisthesis, it means the abnormal shifting of the spine, very common. Compression fractures. Well, unlike arms and legs, when you break a bone there, they sort of break like twigs. In the spine, they tend to compress a lot more like, let's say, an empty can of soda. Few definitions about procedures. Decompressive procedure, also sometimes called laminectomies, discectomies, essentially means taking pressure off nerves. A fusion means growing bones together, typically used to stabilize things long term. Kyphoplasty is a minimally invasive procedure used to put bone cement into an injured bone as essentially an internal brace. Lastly, minimally invasive. I mean, what does this even mean? Well, unfortunately, there isn't really a great definition, but essentially using the least traumatic techniques. So trying not to damage stuff, to do the normal job that you would do in a traditional procedure. That's all minimally invasive means. It's not really about the size of an incision, although typically it does mean smaller incisions, but it means when you're going and doing the work, you're trying not to traumatize all the normal tissue in order to do the job. Well, what about benefits? So what's so good about less invasive or minimally invasive techniques? Well, I mean, there's less problems, less blood loss, less transfusions, less damage to the tissue, shorter hospital stays, less pain, quicker recovery, lower infection rate. Those all sound like pretty good benefits, right? And I'm going to emphasize this, but we're talking 2 to 3 times. That's 200 to 300% less infection when you use these techniques. That's a pretty big deal. So what about this trauma? I mean, when you're doing traditional surgery, I mean, where's the damage? It's all these muscles and ligaments, and unfortunately, it's not necessarily just where you do the work, but typically when you have to open things up, and we've got a few pictures that I'll show you, and you know, they say a picture's worth 1,000 words, but when you have to open things up with traditional techniques, you're not just having to open or injure the area where you work, but the surrounding areas. And that's part of the challenge and part of what we're trying to avoid. So really, the question is not so much what's wrong with traditional surgery. I mean, in a way, there's nothing wrong with it. It's just, can we do better, and should we always be trying to do better? And it sounds to me like better would be less blood loss, less pain, shorter hospital, fast return to activities. I mean, that's what we should always be trying to achieve. Well, why don't all spine surgeons do minimally invasive techniques? I mean, it all makes sense, so why isn't everyone doing it? Well, there's actually an easy answer. It's hard. It takes a long time to learn, and despite the fact of how long it's been around, I mean, I started doing it in 2001, it's not really taught in training programs. So you do all this education and training. Well, often, typically when you come out, you haven't learned these techniques, and then you have to go off and learn them on your own, which is not so easy. So I just, by luck, I was introduced to these techniques, which some of these weren't even around 20 years ago. And I thought, wow, this is the future. I better learn this and be really good at it. And I committed myself to it. And so I've been doing this now almost 20 years. And this is just a small picture. We have a lot more of trying to show the difference of how you have to really open things wide with a traditional or open surgery versus just opening a much smaller channel with minimally invasive, okay? So you're working through, and this is for most of the posterior surgeries, whether it's neck, mid-back, or low back, some kind of working channel. a little tube or cannula in order to see and do the work. You can move those channels around, you can do instruments through them, and this is a picture of somebody's low back, 2 incisions about 1 inch long, after having a very common minimally invasive spine surgery with screws and rods and spacers. Now, I'm not saying every surgery has those things, but when you hear that, it sounds awful. When you look at that picture, it doesn't look so bad, does it? Well, what about an open surgery? I mean, isn't that similar? Now, this is a little bit of a bigger surgery, but when you look at that, that looks awful. But that's real surgery when you have to open things up. You have to strip off and peel off the muscles in order to do the work. I'm not saying it can't give you good results, but how can that not be pretty damaging? So if we can avoid that, if we can do the same work on the inside and not do that on the outside, wouldn't that be better? So I'm going to show just a few pictures of a case of mine. And this is an old case. This is like, I hate to say, 10 plus years ago. This is me in the operating room, and we rely a lot on technology. If you can't see everything with your eyes, you need the technology to help you. I use a lot of 3-dimensional x-ray technology. We do live nerve monitoring. There are other technologies out there. This is working through that little cannula. That's me, you know. And I'm using an instrument through that. Now, that's the outside. When we take an x-ray, now that's where I can actually see, you know, what I'm doing and the anatomy. Same kind of thing, putting a little instrument through an incision, putting in surgical hardware. This is, again, what it looks like on the outside. That's what I'm doing on the inside. It's really amazing that we can do this kind of stuff, and we can't see that much with our eyes here, but with the technology, we can see exactly what we're doing. This is that patient after the surgery. She's still on the operating table. It doesn't look too bad. That's what it looks like on the inside. That's an awful lot of work. Doesn't look like it there, okay? So we minimize the trauma. I'm going to show you a bigger case, and again, a lot of what we do is really small. It doesn't include screws and rods and all that terrible sounding stuff, but that's not quite as exciting to look at pictures, to be honest. So we're showing you the really interesting looking stuff, but I don't want anyone to think that everything we do includes, you know, implants and things like that. But to give you an idea of the scope of things, now that's a lot of incisions. That's a couple weeks afterwards. It doesn't look that bad, but that's adult scoliosis surgery. Now, I can tell you, if you did this with a regular incision, that's how long the incision would be. And I could go back to that slide that showed the open surgery. That's what that's going to look like. Honestly, that doesn't look as bad, right? But just to show you that whether it's the simplest little stuff or really some of the most complicated, these same techniques can be used. So I've emphasized this because I don't want to scare everyone away. You know, it is, again, much more interesting to show all the big, interesting stuff. The truth is, if we showed you pictures from doing a simple decompression or laminectomy, there's hardly anything to see. So, you know, we've illustrated some bigger stuff, but same exact thing, very limited way for the little stuff. And that's an introduction.
Okay.
Questions?
We have a few questions. What are the symptoms of a possible spine condition? What is some of the things that people are going to feel?
So, of course, the most common thing people come in with is back pain, right? Or neck pain, which, what does that mean? It means pain, I hate to say, simply in the back or the neck. Now, nerve-related pain, which there are different terms, whether it's sciatica, radiculopathy, pinched nerve pain, call it what you want, is where that pain doesn't just stay in the back or the neck, but travels down into the arms or legs. I mean, those are our most common presenting symptoms.
At what point there are alternative treatment options before surgery for back and neck pain sometimes? So what are some of those? And then at what point does someone need to have surgery?
So I wish I could tell you everyone needed surgery. Unfortunately, that is not the case. Well, first, if you do nothing, and I'm not necessarily suggesting it, we know that a lot of people will get better just through time, right? Now, if you're in pain, even if someone tells you, hey, do nothing, just wait, you're going to feel better in a couple months. I mean, wouldn't it be nice if you could do something else? So there are medicines that you can try. We do, as much as possible, try to avoid narcotics, but a lot of it revolves around anti-inflammatory type of medicines. For some of the more chronic problems, there are some different medicines as well. I don't do a lot of medical management like that. There are other doctors in the community who do, but medicines often are a place to start, and even at home, your ibuprofens, naproxens, things like that. I mean, that's usually the first thing to reach for, assuming you don't have medical conditions or things that you can't take them. Besides medicines, there's physical therapy modalities. That can include traditional physical therapy with a therapist, chiropractic therapy, even other alternative things like acupuncture, massage. Every one of those things has been shown to be potentially helpful. After those two things, you get a little more invasive, but still stay less than surgery with injections. Though there are very specific spinal injections. These are done only really by qualified, trained individuals, typically not in an office, but in a procedural kind of setting that often can be very helpful and, hopefully avoid surgery or potentially delay it. And then if all that fails, you're unhappy enough with the quality of life, you have the right problems, you have the right imaging that matches the problems, you understand the risks and benefits, then maybe surgery is worthwhile.
Okay. Do we have any other questions? I don't think we have any other questions, so thank you, Dr. Kravetz. If anyone would like to schedule an appointment, they can call his office or visit online at cullmanregional.com.
Thank you.